medications. So does anybody, has anybody had the opportunity in clinical? Let's see. Would you have seen anything like amiodarone? Because you can actually give that by mouth. Has anybody had the opportunity in clinical to see a rhythm order or dysrhythmia? AFib, maybe. That's usually one of the most common ones if you've had any geriatric patients. Anybody got any scoop on that? AFib, okay. How do they treat AFib, Chelsea? What was your patient taking? What would somebody take with AFib? Yep, there you go. And yeah. Beta blockers are pretty good too. Calcium channel blockers, indeed. We're going to talk about a couple of other things. Certainly some heavy hitters. Yep, there you go. Combination therapy, absolutely perfect. So there are basically four lethal heart rhythms. Um, we're going to talk somewhat about those and what can repair them or reverse them, if I may use that. So you have, of course, PVCs, which are premature ventricular contractions. We have VTAC, we have VFib, and then we have something called torsades de pointe, which is basically polymorphic VTAC. And if you see the rhythm strip, it gets wide and then it gets, because it's just a ventricular response. Okay, it all you see are the ventricles that are the ventricular wave, but it'll get wide and then it'll get narrow and it'll get wide and it'll get narrow. And when you see that particular rhythm strip, you know it's probably a kiss of death. So we're going to talk about a couple of antidysrhythmic drugs. The first of which we'll talk about is amiodarone. So amiodarone is one of those drugs that you can give by mouth. A good bit of the other ones will be intravenously, certainly push, particularly if it's during ACLS or cardiac resuscitation for sure. Um, it's typically given for sustained ventricular fibrillation, ventricular tachycardia. Anything, if CPR is not working, then somebody's going to step in with amiodarone. Um, and certainly during defibrillation, um, out of hospital cardiac arrest, um, most of the time lidocaine is not recommended as an alternative simply because lidocaine carries its own set of problems and certainly has a lot of disadvantageous side effects. This medication is certainly used, amiodarone is certainly used to treat serious fatal arrhythmias. One thing about any of these dysrhythmias, they can have something called pro-dysrhythmic uh, potential. And what that means is you can give anti-dysrhythmic for a rhythm disorder, and you could actually make it worse because sometimes in the process of trying to reverse the dysrhythmia, you can actually kick it up a gear into something worse. For instance, you could change VTAC, which is just a very accelerated heart rate, into something like VFib. Um, which is, certainly fatal, at least a good bit of the time. And certainly, amiodarone is given for recurrent arrhythmias. Um, it's definitely very liver toxic. You certainly don't give it in bradycardia for self-explanatory reasons. People with congestive heart failure usually aren't recommended this drug either. Um, It certainly, if the heart muscle is extremely damaged, unless it's a last ditch effort, of course, um, it's very vulnerable. The heart's very vulnerable. Um, Valve disease is another contraindication. Low potassium can cause it, and certain medicines can also cause AFib. So we'll look at those certainly as we go forward. Um, Lidocaine is another drug that's given for dysrhythmias. Lidocaine is also used in what other situations, not concerning the heart? Does anybody have any idea about lidocaine? What would you give lidocaine for? Local anesthetic, absolutely. You can either give it with epinephrine or without epinephrine. If you give it with epinephrine, it stays more localized. If you give it without epinephrine, and I've seen it given with a drug called Rocephin, because Rocephin is a very painful drug when you give it IM. And so if you give lidocaine with it, without epinephrine, it kind of takes the sting off of it. With epinephrine is what you give usually if you're doing local stitches or anything like that, because it keeps the lidocaine in the localized area. Um, lidocaine is lidocaine is significantly better than amiodarone for BFib, particularly in MI. So what lidocaine does, it's an antiarrhythmic agent. It has moderate efficacy against ventricular arrhythmias, particularly SVT. Um, it is useful in the setting, particularly when there's myocardial ischemia or infarction. It may be used as an alternative to amiodarone in the management of refractory ventricular fibrillation. So refractory means that it's if you have given an anti dysrhythmic drug and it's caused has a prodromal effect and it makes it worse, then it becomes a refractory to the former medication. So you can give it in cases of refractory fibrillation, which means it didn't work with the first drug you gave it. Um, so procainamide is another drug. Procainamide is a medication that's used certainly for antiarrhythmics in the treatment of cardiac arrhythmias. It's um, most of the time it's given for AFib, RVR, AFib with rapid ventricular rate. So your atria are like fibrillating or quivering, but then your ventricles on the bottom are responding very quickly, but they're out of sync. So usually in a normal, typical rhythm strip, you have a atrial beat and then you have a ventricular response. But in the case of AFib with RVR, you have a quivering atrium, it's in fibrillation, and then you have a rapidly responding ventricle, but they're not in sync. So procainamide is particularly given in the case of AFib with RVR. There's another arrhythmia called Wolff-Parkinson-White, and it's actually when you have an extra electrical pathway coming from the atria to the ventricle. So it'll be randomized ventricular responses. So you could have like a atrial beat, ventricular response, atrial beat, two ventricular responses. So in Wolff-Parkinson-White, you have an extra electrical impulse coming down from the atrium to the ventricle. A lot of times, this particular arrhythmia is treated with something called an ablation, a cardiovascular ablation. Procainamide is also used as an emergency rescue before ablation. Certainly, other drugs can be used for aflutter, diltiazem, which we'll talk about in a little bit, and also which is a calcium channel blocker, and then also beta blockers as well. And as a reminder from Pharm 1, you don't ever give Viagra to patients who are on nitroglycerin and a lot of these cardiac meds as well. Let's see. So we talked about procainamide. It's typically used in the treatment of stable complex tachycardia. And what I mean by stable is when they're hemodynamically stable. So if somebody has hypovolemia and they're going into cardiac arrest, then they're not hemodynamically stable. So procainamide would not be the drug of choice in those particular patients. Verapamil, okay, we learned about verapamil in Pharmacology 1. It also um, is given as an antiarrhythmic. It's the most widely used calcium antagonist for ventricular rhythm or cardiac arrhythmias. It is actually sometimes one of the go-tos, particularly if there's some other issue with the heart, some other pre-existing issue. Um, it's given it can be given along with a beta blocker. Sometimes they're used in combination if need be. I talked about diltiazem as a calcium channel blocker. It's given a lot in A flutter. Sometimes the best thing for A flutter is just to cardiovert it. Because remember, sometimes you have to shock the heart out of that particular dangerous rhythm. It kind of resets it. You stop it. Of course, if you do cardioversion, you're medicating your patient with um, Versed, and certainly sometimes it's done under anesthesia. Metoprolol, a beta blocker, a lot of times for the maintenance of chronic dysrhythmias, your patient can take a beta blocker. Remember that beta blockers and are known for orthostasis, ACE inhibitors, and ARBs as well. So anytime your patient is on a beta blocker or a calcium channel blocker for a dysrhythmia, always pay attention to orthostasis. Beta blockers and calcium channel blockers have very similar effects on the cardiac action potential. They reduce automaticity in the SA node. So what they do is they basically, as in a beta blocker, they block the recurrent or the aberrant electrical conduction from the SA node um, through the through the bundle of His. And certainly, like I mentioned, they're known to cause hypotension as well. Um, as we learned in last semester in Pharm 1, metoprolol can mask the signs of hypoglycemia, and blood sugars should always be monitored. Hang on just a minute, guys. Sorry, I forgot to close my door. And I turned on the light and I can see better. So, like I said, always check blood sugars in if you're given beta blockers. Let's see, labetalol, of course, same thing. It's an antidysrhythmic drug with pro-dysrhythmic effects. It's a it's a good drug. It's got a less side effects than some of the other ones. It has certainly the potential of controlling rhythms, particularly following myocardial infarction. Um, you don't use it if there's an AV block, as the name suggests. It's a beta blocker. So if there's already a block in place, you certainly don't use that. Um, let's see, certainly, propanolol is contraindicated in the use when there's asthma. And it's because it's a non-selective beta adrenergic agonist, and certainly it can cause bronchospasms. So if your patient has congestive heart failure or asthma, anything where there's respiratory involvement, beta blockers, of course, aren't indicated. It's used certainly in the treatment of many cardiac dysrhythmias. And propanolol slows the ventricular response, which is actually what we're trying to do to prevent secondary dysrhythmias that are worse. Atropine is a drug that's used to dry up secretions. It's used as typically it's indicated for the treatment of bradycardia. Of course, bradycardia is significant or 60 below. There are some rhythm strips that are available for you to look at, certainly in the reading. It's indicated for bradycardia. It's associated with hypotension and certainly second or third degree heart block. It's no longer recommended for asystole or PEA because it has a tendency to cause sudden death if given in those situations. Let's see. Adenosine. Adenosine is one of those antidysrhythmics that is kind of a bonus drug because while it slows conduction through the AV node, which means that it's very good for AFib, um, it also has the capacity to dilate coronary arteries. And you know, when you dilate your coronary arteries, you allow better blood flow to the heart muscles. Um, Adenosine is the drug of choice for PSVT, which is paroxysmal supraventricular tachycardia, which means that the electrical impulse is coming from not a consistent site. And certainly, once again, advanced cardiac life support um, from ventricular tachycardia is also very advantageous with this drug. We talked about digoxin last semester. Digoxin is given in heart failure. Certainly, it's not the first line of treatment for heart failure, um, but it's usually given along with other medications, certainly Lasix. Um, Unfortunately, like we talked about many times before, Lasix will wash out the potassium, which may induce an irregular heart rate. Because it also washes out the um, potassium, it can cause um, low sodium as well. Let's see, treating heart failure certainly is an ongoing thing. Um, Beta blockers and calcium channel blockers are certainly preferred over digoxin, but sometimes in the lack of um, other indications, sometimes digoxin is given as a last ditch effort. Okie dokie, epinephrine. So we've talked about epinephrine when it was with anaphylactic responses. Epinephrine is also used in cardiac arrest. It increases the arterial blood pressure. Um, it causes a vasoconstrictive effect, which of course can shunt blood back to the core. In the heart, it increases the rate and force of contractions, and it increases output of the blood to raise blood pressure. It stimulates the breakdown of glycogen to glucose, and certainly it will also result in increased serum glucose. So I kind of stumbled through that, guys. I should have got some water. The risk of using antiarrhythmic medications in older adults. Older adults are more susceptible to side effects of antidysrhythmics, including bradycardia, orthostatic hypotension, urinary retention, and falls are all side effects. What do antidysrhythmic medications contribute to the development of arrhythmias? Antidysrhythmic agents can worsen arrhythmias by increasing the duration or frequency. Certainly, they're considered pro-arrhythmic, and they can increase the number of premature complexes. So once again, unless the antidysrhythmic is able to sync the dysrhythmia, sometimes it can make the dysrhythmia worse. Um, by making it further out of sync, by making the rhythm further out of sync. What are the indications for the use of procainamide? Ventricular arrhythmias, sustained ventricular tachycardia. Certainly, when you're given procainamide, it's in the event of life-threatening dysrhythmias. Side effects include nausea, vomiting, loss of appetite, flushing, of course. When you're trying to decrease the heart rate and decrease contractility, you're driving calcium out of the cells, and it causes a flushing effect or flushing responds. Sometimes it can either cause itching or rashes. What medications interact with procainamide? About everything. Um, Unfortunately or fortunately, if someone's getting procainamide, you are not very concerned about any sort of drug reaction. Let's see, what are the indications for the use of lidocaine? If the rate is, it's usually rate, it's given by rate. If the rate is 180, which is considered VTAC, of course, and the patient is conscious, um, you give O2 and lidocaine. It does so by stabilizing um, the heart rate. It's certainly given for ventricular arrhythmias, like we talked about at the very beginning. Let's see. The adverse effects of lidocaine, of course, anytime you give an antidysrhythmic drug, you can expect that it may have a very paradoxical effect. And because it may not decrease the heart rate, it may lower the cardiac output, therefore lowering blood pressure. There's always redness at the injection site if you're giving it um, IM. Sometimes it causes skin irritation, constipation, and nausea and vomiting. What medications interact with lidocaine? Um, Fentanyl, a lot of the pain medications, a lot of the CNS depressants interfere with lidocaine. You should not receive lidocaine if you're allergic, of course. If you have severe heart block uh, and have a heart rhythm disorder called Stokes-Adams, but I've never even heard of that one. Indications for the use of propranolol, labetalol, and metoprolol. Beta blockers increase the heart rate and cardiac output, which can lower blood pressure which lowers blood pressure by blocking the effects of the adrenaline. They're used as therapy for cardiac arrhythmias and certainly treat chest pain as well, angina. Adverse effects of propranolol, labetalol, and metoprolol. Of course, orthostasis, poor circulation, fatigue, dizziness, sexual dysfunction. How is the effectiveness of propranolol determined? Propranolol is a type of medication, of course, called a beta blocker. Effectiveness is determined if your arrhythmia is gone, your blood pressure is down, your cardiac output is significantly normal, and you hadn't passed out because you don't have orthostasis. Amiodarone, like I mentioned, it's for a certain type of serious fatal irregular heart rate, dysrhythmias. It's one of the drugs of choice in ACLS. It works by slowing down the reactivity or the ventricular response. It certainly relaxes an overactive heart. And the goal is, of course, to eradicate the arrhythmia. Amiodarone is administered certainly for VTAC, VFib intravenously. It's also given intraosseously in the case of emergency, patients unable to get IV access. It can be given bolus for cardiac arrest. It's used certainly after the third shock. As with ACLS protocol, you typically shock 3 times and then you begin other measures. Amiodarone is one of those drugs that you'll give after the third shock. I wish, I hope that at some point all of you have the opportunity to take ACLS. If you go to work in the emergency department, ICU, ACLS is one of those skills that very few nurses possess. And if you're interested in emergency medicine at all, it's very fascinating. I particularly love cardiac. I mean, I may, in fact, I may record this uh, lecture. So, I might make it a little bit clearer. It's been kind of a long day, and I'm a little bit uh, talked out, but I really do love cardiac, and I certainly love emergency medicine. So ACLS is one of those skills that teaches you all the dynamics of cardiac resuscitation. It teaches you all of the kind of the interesting um, rhythms that go along with the different dysrhythmias, and certainly you can look at a rhythm strip when you get to critical care and be able to tell either what drug they had or what drug they need. So very fascinating. So I think I already mentioned the side effects of amiodarone. It's liver toxic to remember for your exam. And certainly if someone is itching and they're yellow, and you can always imagine that those are certainly either medicated related side effects and or um, other disease processes that are affecting the liver. What medication is the drug of choice for treating VFib? We talked about epinephrine. Um, is if it's not effective, amiodarone is certainly given as well. Amiodarone is the drug of choice, by the way. Let's see. Epinephrine is one of the drugs that is also used in ACLS. How do verapamil and diltiazem work to manage arrhythmias? It remains a most widely used calcium channel blocker. Um, Certainly, it's very common, and certainly it can be given uh, by mouth. A lot of times it's even given with DIG um, because it suppresses conduction, or excuse me, given instead of DIG when DIG becomes ineffective. Let's see, 3 common cardiovascular adverse effects of calcium channel blockers. Of course, calcium channel blockers block the calcium channels, and they can lead to hypotension, bradycardia, and certainly heart block. Anytime you block the channels that allow the AV node signal to go to the SA node, then certainly you may expect heart block, and that's one of the side effects of these calcium channel blockers. Calcium channel blockers should be used with caution in hepatic injury, of course. Most of the drugs that we will talk about this semester are that way. Medications that interact with verapamil, DIG is one, carbamazepine is another, and sometimes beta blockers if their blood pressure is a little on the low side. Adverse effects of verapamil and diltiazem, we talked about that actually. Dizziness, lightheadedness, AV block, flushing. What antiarrhythmias are indicated? What arrhythmias are indicated for the use of DIG? Of course, heart failure, AFib is the only thing I've really seen it used for. Adverse effects, of course, we have already talked about digoxin, and we have already talked about how toxicity, halos around lights, things like that. Medications may be used to manage SVT, beta blockers, calcium channel blockers, SVT. Sometimes these ventricular tachycardias cannot be controlled by anything, and so you either do an ablation where you actually stick a catheter in the heart, thread a catheter through the heart, and you ablate, which means you take an electrode and fry where the signal is coming that is triggering the heart to continue to beat out of control. That's actually one of the most effective treatments for SVT, or supraventricular tachycardia. Let's see, adenosine is certainly the first line treatment for SVT. Always check the rhythm. Anytime your patient's on adenosine, anytime your patient's on any antiarrhythmia, we're always going to have them on a continuous EKG. So always remember that. Adverse effects of adenosine, we talked about that already. Flushing, difficulty breathing, chest pain. A lot of these drugs, when they're attempting to control any sort of dysrhythmia or dysrhythmic rhythm, you can expect difficulty breathing. Your heart is not pumping enough and enough with enough pressure to get to your lungs, and so certainly your lungs are not responding favorably. Uh, Oxygen is not being transported as effectively. Your patient becomes short of breath, and when they become short of breath, usually they're lightheaded and dizzy. Anytime someone's hypoxic, too, usually they're tingling in their fingertips, they experience numbness in their extremities, and those are all effects of inadequate respiratory effect. Let's see, epinephrine. Why is epinephrine used to treat dysrhythmias? Because it reduces the ventricular fibrillation threshold, although it's also used during fibrillation just because it helps respond or reduce the refractory period. So when your heart's beating, it has a very quick refractory when your ventricle is fibrillating. There's no refractory period. So if if the epinephrine can sometimes slow it down, and the refractory period is prolonged. Let's see, three dysrhythmias where epinephrine can be used: VTAC, VFib, and pulseless VTAC. So pulseless VTAC means that your heart is just beating. Your ventricles are just beating, but it's not pushing any blood out. So at that point, of course, there's nothing to lose. And so a lot of times in the last ditch efforts to resuscitate someone, they'll just push epinephrine. Um, and that's usually a very sad state at that time. What rhythm is atropine used for? Bradycardia. That's the only rhythm that it will be used for ever. It'll be used for other things, drying up secretions in surgery, and that's about it. So I've gone through this stuff rather quickly. I will probably re-record the beginning of this lecture just so I can go through very more clearly and distinguish between amiodarone, lidocaine, and procainamide. Certainly diltiazem as well, because I kind of went through that rather quickly, and I may have left out some major things. Does anybody have any questions? Professor Padilla? Yes. Professor Padilla, I think you posted the blueprint, right?
I think I saw it listed on this weekend's posting, if I'm not mistaken.
Oh, yeah, that's right. I did.
Let me double check. Yeah, I think I saw it listed there. It's called the blueprint. Let's see. Test plan. Let me share my screen so you all see what I'm looking at. And if you can't access something for whatever reason, just let us know. Where is it? Share. Nope.
It should be in there.
Can you all see my screen?
I can.
Okay. So it's this one that's called the Exam 1 Test Plan. And let's see if it'll open up.
Yes. Let me see if mine will open up.
Yeah, mine's taking a while for some reason. Unless it says,
Announcements. Yes. All of the things will be in the announcements.
oh, there we go. And Dr. Clazel was nice enough to also post the review. So you already have that available. Sorry, my computer's lagging. There you go. Here's the test plan. So that's what it looks like.
Oh, those are pretty. Did everybody get it? Or can everybody open it? Everybody got it. Can everybody open it? Okay.
Good deal.
All righty. That was a whole lot of information to throw at you at once. Let's see.
All right. So I guess we're going to determine what day we'll hold
Yeah.
exam review.
So we had some at the beginning of the class. I asked, and we had some Sundays and some Mondays. I think if I go through the chat, I think that so we have some students taking the exam on the 8th. Some have clinical Sunday. And the 8th is what, Tuesday? Yeah, the 8th is on Tuesday. Monday morning. Yeah, it'll be recorded. Let me look at my Monday. Let's see. I mean, I could answer questions on Monday morning at 8 o'clock, or I could be available to answer questions. I don't know. Professor Padilla, when is the better time for you to do the exam review?
Probably the afternoons, anytime after 4.
Yeah, that's the better time for me. Let's see. Batteries running. Oh. Computer's not plugged in. I wonder why. There we go. One plugged in all the way. So how about I don't know, Professor Padilla, what do you think? I think I have decision fatigue.
I mean, unfortunately, I don't think we'll ever be able to capture everyone. We could, I mean, y'all have the review already, so you have that in advance. We could try to do like maybe 2 short reviews with everyone, or we could do a recorded review and then just make ourselves available like Monday, Tuesday afternoon for questions that aren't answered either in the review or recorded review.
Yeah, some of them have it on Tuesday. So that's a good idea. How about we do a recorded review and then we are available. What's good for you, Professor Padilla, on Monday? I apologize. I should have brought this forward before tonight. Since the exam schedules have changed so profoundly, it's been um, certainly the semester's gotten away from me. So I apologize for waiting till this late a date. Now I didn't do the cahoots, Susanna. Professor Carson did the cahoots. So and yeah, those were cool, but I didn't do the cahoots. Professor Padilla, last semester, Professor Carson, who taught Pharm 1 on the trad side, would, since we all teach the same class together, um, we would send the recordings for Pharm 1 over to her, and she did a Kahoot, and I think two times out of the exams she shared them with us. So yeah, no, I'm sorry, we didn't do the Kahoot, but I don't do the Kahoots, um, so I apologize about that. But anyway, what I was saying is that we can certainly record a review, and then we can be available. I don't know what time Monday works for you guys. What time works for you, Professor Padilla?
Anytime after 4.
Okay. How about 5? I see, where do I have? How about 5? Is 5 too early?
Not for me.
Is 5 okay for everyone? Oh, clinical Monday. Okay. I
You have
gotcha.
clinical on Tuesday because we're trying to make ourselves available Monday and Tuesday.
Yeah, Abigail has clinical on Monday. So how about this? How about this? And they have skills too.
On
So how about
Tuesday.
this? They have their test is Tuesday, I think.
Oh, for our class?
Yeah.
Oh,
Yeah, their
that's
test is
not
Tuesday.
Sunday. Okay, so yeah, all right, right there with Dr. K. We're totally thrown off because every semester up to this one
Yeah.
exams were on Friday.
Yes.
Okay, gotcha. Okay,
Yeah.
so classes are canceled tomorrow. So right?
Right.
So tomorrow, Thursday.
We could do one tomorrow.
I mean, we could have everything recorded. Maybe we could record and release tomorrow, and potentially classes will still be postponed Friday. Maybe Friday, Saturday. Does that work? Or tomorrow would
Tomorrow?
work? Yes. Okay.
Yeah,
All right.
that's great.
So maybe we do exam review tomorrow.
Yeah, we could do exam review tomorrow. I'm available. Um, let's see, I have a 9 o'clock meeting, 9 to 10, and then I have a 2 to 3. So we could certainly do it whenever tomorrow.
Tomorrow, let me check my schedule. We're all working remotely because of the
Yeah.
weather, so I might have some more flexibility. I'm available between 12 and 2, and probably, actually, I could make myself available anytime after that. So, um, yeah, anytime
We could do
after 12.
3 to 4. We could do 4 to 5. We could do 11 to 12.
Well, I think everyone's going to be accessible tomorrow, right?
Okay. Yeah.
Everyone will have a little more availability, not having to commute to clinicals or the campus. So if you all are okay, Dr. K and I will discuss and confirm a time and post it under the announcements.
Is
If
that
that
okay?
sounds like